Hello, my name's Adele Jones and I work at Gloucestershire CCG. I'm Associate Director for Clinical Programmes and I'm the Programme Lead for a Pain Clinical Programme Group and the MSK Clinical Programme Group.
Hello, I'm Susie Durrell. I'm Consultant Physiotherapist at Gloucestershire Hospitals NHS Foundation Trust, and I am a member of the Gloucestershire MSK Clinical Programme Group.
The MSK Clinical Programme Group started a number of years ago, probably 8-9 years ago, or maybe a little bit more. The whole concept of a clinical programme group is to work with a variety of stakeholders across a particular pathway. So for MSK, we were looking at working with our physiotherapy, therapists, podiatry colleagues, the GPs, orthopaedics, rheumatology, pain, to actually try and understand the whole pathway in terms of how the patient experiences it, the benefits, the good points, and what works well and what doesn't work well. So they're made up of those clinical participants, but we also have people from the CCG. So there are business analysts, we've got people from our quality team, we've got our data analysts there, and we also have patient representation. The whole idea of a clinical programme group was to look at the whole pathway from beginning to end and to look at and see what we can do better in terms of the pathway. And that might be for a number of reasons. It might be to increase efficiencies, save money perhaps. We might be looking at safety. We might be looking at patient experience. And we tend to find that if you look at all of those things, you can often benefit a lot of things together by improving the whole pathway.
So I'm one of what I would hope to be the lucky people who's been part of the commissioning clinical programme group since about the 8 years. So one of the long-standing members, and I think one of the clear reflections from us all is the amount of time it takes to build relationships across these complex systems of care. We have celebrated, we've won awards as an MSK clinical programme group. And I think that is a reflection of building those relationships, but the complexity of MSK is how many subspecialty areas are involved. So as much as everyone might have the patient's best interests at heart, we're actually in a system where we are working collaboratively, but also under competition at times. It's important for us to try to share a strong vision, but it helps also to break down boundaries and to challenge any silo working. And I think that's been one of the real benefits and one of the outcomes, that we don't always agree about everything and we have some strong opinions, but if we align some of those opinions and we continually think about our patients with a strong patient representative, we actually usually come up with the right outcomes and the right answers.
Can I just ask about your clinical colleagues? When I think about orthopaedics, for example, I think of consultant orthopaedic surgeons. Do you have a view on how these stakeholders can be brought into this sort of endeavour?
I think it's not a role or a perspective that suits all of them. It does very much come with a leadership aspect of the role. But of course, we are actually all working under our own provider umbrella as well. And I think the challenge is to get the right people in the group to challenge each other and the commissioners to challenge us to make sure we're thinking about patients first. And we're not always just reflecting our own narrow perspective, albeit we need to function at all levels with our objectives met in each part of our role.
I'd agree there with Susie. Some of this is sometimes quite difficult, and it is about relationships and it is about understanding one another. So whilst we do have a regular meeting as a whole clinical programme group, there'll be other meetings happening outside to actually try and understand people's perspectives, try and make sure that we understand where they are coming from, and whether it's their opinions or whether it's what they think they should be doing on behalf of their organisation. And everybody brings a history with them, and sometimes it's quite interesting to unpick that and to unpick people's motivations. But as Susie says, most people there are there to do the right thing for the patient, and that's what we kind of hold on to as a group.
So we have a particular example which may illustrate some of the joined working through the programme group. And we've expressed that there are many specialties involved in the MSK pathway, and we express the pathway for the patient as an integrated approach. But one particular part of redesign that we're very proud of is the MSK specialist triage aspect, which I'll explain. This is where we've implemented an electronic single point of access for primary care teams, particularly GPs, to refer patients for a specialist opinion. And that opinion may be the opinion from an advanced practitioner who may be a physiotherapist or a podiatrist or a hand therapist, or it indeed may be through an opinion from an orthopaedic surgeon. But we joined the access so that it is mandated, and that team of specialists can decide the most appropriate clinician provider that can take the conversation forward and move the patient's journey forward with a diagnostic opinion, plus or minus further investigations. But it really is on the premise of right person, right place at the right time, and very much relies on the clinical teams supporting each other and working in a multi-professional way.
So this was a really complex thing to do. So it sounds relatively straightforward, but it wasn't. And that's because we had all sorts of things in terms of commissioning, all sorts of contracts that initially weren't working for us and had to be looked at and changed. So, for example, we actually made sure that the providers who were providing a service previously were paid the same. And that wasn't necessarily happening before because of historic difficulties. So we had to start off in that way. What was really interesting for us, though, is at some point NHS England mandated this kind of approach. And we were already, the clinical programme group had already decided this is what we wanted to do, which I think is really interesting because, you know, we put everybody together. They could have chosen anything that they wanted to work on. They had a very strong vision that this was the right thing to do. And then it was actually mandated a little bit later on. So we were able to work with providers and the teams to actually go to the contracting elements to make changes to the contracts, with the clinical programme group standing behind us with this very strong vision. So whenever we had to go to anybody to explain what we wanted to do and why we wanted to do it, it wasn't me as a single commissioner, it was me with the clinical programme group sitting behind me, actually telling us it was the right thing to do. And that was very powerful.
So in addition, the benefit of working in this way was about making sure the patient's pathway wasn't duplicated. So patients were not referred into two parts of our integrated MSK system, which therefore can reduce waste. But in addition, we were able to reduce variation in pathways so that they had a more equitable offer. And we can also apply agreed clinical criteria to what would be the right person in the right place at the right time, and judicious use of diagnostics, meaning if you're having a test, you need to know what the question might be and would the investigation make a difference to your patient journey.
Okay, so what followed on from that is that there was a prediction from the clinicians to say, if we work in this way, you are going to see reduced numbers of appointments in various areas. You are going to see reduced numbers of people having to go to orthopaedics, only to be able to then be referred back into physiotherapy if they hadn't gone the right way. We were able to see a reduction in the amount of diagnostics done because they were being done by the right people at the right time. And therefore, we were able to predict the savings that we might make. We monitored those, and at the end we were able to show that that actually occurred.
The people on the group, I suppose, are very interested in doing the right thing.
Yeah.
But each of those people within their role should have some strategic influence and strategic aspect to their role. So it is part of an expectation to be involved. Value means so many things. The outcome, the patient-centered pathway, is about value-added care. So that's priceless, really. Otherwise, we are just compounding waste in the system, and anything you can do wrongly for one patient blocks another patient from the right care. One of the things that strikes me that we've created is also a system where maybe this is your value, Adele, as commissioners, but we've got a system where we can implement commissioning policies through a mandated pathway. And my positive reflection is that when we've written effective clinical commissioning policies, it has been clinically driven and clinical debate that has led that decision, rather than being very much a referral centre management implementation. And we've had positive change. So I think the time in the meetings has been well spent, and it would be very difficult to engage the whole system and the clinical work teams without having that sense of engagement. So one of the reflections as a leader in a provider aspect of the pathway has been the difficulty we've had with implementing systematic clinical outcome measures. And this has particularly been to do with our digital journey as an organisation and a trust. This has been slower in implementation than we had hoped. So where we have passionate clinicians who wish to be able to robustly measure outcome for their patients, we've really more of an appointments support system rather than a clinical system support yet. However, we've done individual parts of project work, and where we've set up a new program or a new aspect of service, we have needed to go back to paper resource and paper and postage to send measures of quality or outcome to our patients for evaluation. We're really looking at the digital future and are making the case as strongly as we can that outcomes should be part of the priorities over the next phase.
And as far as the CPG is concerned, we have discussed outcomes a lot in terms of the whole pathway, and it is very, very complex to actually get that data. It's something we would love to work on, but at the moment we just don't have an answer for it. Okay, so we're going to talk now about what we think are the strengths and weaknesses of the clinical programme approach. I mean, I'm a huge advocate of the way that we're working together, but there are some things that are more difficult. Getting the patient voice in regularly and the right patient voice is sometimes quite difficult, and that's something I think we can always improve on, and that's something we are looking to improve on. It could be argued that by just taking a pathway approach, we're actually oversimplifying the situation, in that we might look at patients who are on an MSK pathway, but we have clinical programme groups for respiratory, for cardiovascular disease, for eye health, or other areas. What about patients who have got diabetes, a respiratory problem, and have got an MSK condition? We might be oversimplifying their pathway, and it's very difficult to kind of understand the complexities of those patients. And I think we leave that to the clinicians to do, and that could actually be a weakness of the current approach. We've also very much concentrated on adult patients, and I think we need to work a little bit more on understanding pathways for children. Again, they add additional complexities, but that doesn't mean we shouldn't be looking at that. And I'd say, you know, this could be deemed as a strength or a weakness, but it does take a long time to get the relationships and the trust built across the clinical programme group. So you can have that joint vision and you can work together in sometimes quite challenging circumstances, especially for providers, where sometimes it doesn't look as if for their organisation we're doing the right thing for them, even though we're doing the right thing for the patient.
And just to conclude with some further strengths, some of which we've already mentioned, but I think it's about acknowledgement that we have finite resources and we want to use those wisely across very complex systems of healthcare. It's helped us have a more patient-centred and equitable approach, or to challenge each other regarding that. It's definitely built the trust mutually, and therefore helped shared governance across the systems. So more collaboration for quality improvement. And when we have met barriers to change across complex systems, it's really been a facilitator to help change where we had a united vision, which has been very positive.